Hi, I'm Dr. Lauren Henke and the co-host of the NRG Oncology podcast. And I'm here with my co-host, Dr. Stephen Chun. We're thrilled to launch this new podcast series through NRG to expand the reach of NRG Oncology to physicians, patients, research staff, caregivers, and cancer survivors. We hope you'll find this a valuable resource to understand NRG initiatives and trials. Stephen, can you tell us a little bit about where this podcast idea was born?
Thanks, Lauren. For years, I've heard talk in NRG Oncology and the oncology community in general that there's got to be a better way to communicate about clinical trials to the oncology community, to the larger general public who we aim to serve. And one day, I was driving with my kids listening to a dinosaur podcast. I've got a 3 and a 5-year-old, and it dawned on me, if someone could break down complex paleontology for my 3-year-old, why not try this for NRG Oncology? And this really isn't new to medicine. All of the major journals like the New England Journal or JAMA have their podcasts. Sue Yam does a fantastic job with the Red Journal. And honestly, even for me, these protocols, initiatives, consents, updates are very daunting. So I figured that there has to be a better way to simplify things by directly speaking to people in a podcast medium, as is being done for all sorts of things these days.
I think that's fantastic. And we owe all of this to a dinosaur podcast, which is wonderful. So in these podcasts, we're going to be aiming to distill some of the most important information and updates from NRG Oncology in a way that is accessible by tuning in, whether it's on a drive home from work, with a cup of coffee on a Saturday morning, or during a workout in the gym. And in the series, we are going to hear from NRG leaders, principal investigators, patient advocates, and others. And we're really open to anyone who wants to help communicate to further the NRG mission. These topics will include stuff like the basics of clinical trial design, currently active clinical trials, barriers to trial enrollment, and how we tackle timely issues like improving diversity on trials and the patient experience.
For this first podcast, we are excited to welcome Dr. Quynh Lay, who is one of the 3 NRG Oncology Group Chairs. Dr. Lay has truly had a distinguished career in academic radiation oncology. She's led groundbreaking translational research in radiation oncology through her NIH-funded lab at Stanford. She's developed numerous practice-changing clinical trials, both at Stanford and with NRG. And she's currently the McCormick Endowed Chair of Radiation Oncology at the Stanford School of Medicine. In 2013, Dr. Lay had the distinction of being one of very few radiation oncologists who were elected to the Institute of Medicine in recognition of her contributions to medicine.
What a list of accomplishments, truly. Dr. Lay, thank you for joining us. And I know this is maybe a basic start point, but can you speak a little on what exactly is NRG Oncology and what is its mission? And why are clinical trials so important in oncology?
Well, first, thank you for having me. It's a privilege to be able to speak with you about NRG Oncology. It is a nonprofit research organization. It's one of the 4 adult groups of the National Clinical Trial Network, NCTN for short, that is funded by the National Cancer Institute to conduct multi-institutional trials, primarily late-phase trials, to improve the standard of care and to inform clinical decision-making, as well as to inform healthcare policy. So our mission, as said, is to improve the lives of patients with cancer by conducting practice-changing multi-institutional clinical and translational research. And the goal, as I mentioned before, for clinical trials is to bring new drugs, new technology into the clinic to help making the decision in the clinic for the care for our cancer patient and to inform policy. And we also focus, in addition to treatment, cancer screening and patient quality of life and cancer detection.
So, Dr. Lay, last year we celebrated NRG Oncology's 10th anniversary. Could you also tell us about the origins of NRG Oncology in the legacy groups like the NSABP, also known as the National Surgical Adjuvant Bowel Project, the Radiation Therapy Oncology Group, or the RTOG, and then the GOG, the Gynecologic Oncology Group. What were these origins for NRG Oncology?
Yes, we were officially formed in 2013 by the three legacy groups, as you mentioned. The N is for NSABP, the R is for RTOG, and the G is for GOG, and that's why it's NRG. Each of the three legacy groups were well-known international leaders in their own areas of research, with very little overlap, actually, between the three groups. NSABP was very well known for their breast and GI cancer research. GOG was known for GYN malignancies, and RTOG was known for its research in radiation and combined modality therapy in locally advanced tumors across the different disease sites, especially brain, head and neck, thoracic, GU, and certain GI tumors. So when we got together, we really focused on leveraging the strengths of the three groups to create this new organization. And we focused on two themes because based on the strength of the group, gender-related malignancies, which would include breast, prostate, and GYN cancer, and localized or locally advanced tumors in the brain, head and neck, thoracic, and GI sites. So all this actually gives us the current structure of the disease-specific scientific committees that we have within NRG.
That's such a fascinating history. And I think to people who are newer to the organization, understanding those roots really helps to understand the shape of the organization as it is now. Now, you've been involved with NRG Oncology Group and the RTOG Legacy Group also for a long time, Dr. Lee. Would you be willing to share with our audience a little bit about your own career with RTOG and NRG Oncology?
Well, I started learning about RTOG when I trained at UCSF as the radiation oncology resident. And at that time, I trained with Dr. Quynh-Thu, who used to lead the RTOG Head and Neck Cancer Committee prior to Dr. Quynh. So I remember learning about the many RTOG trials during my residency training and how to apply them to clinical practice. I also had an opportunity to attend my first RTOG meeting during residency when one of those semi-annual meetings was in San Francisco. So at the time, I really dreamt about being involved with the organization one day. When I started my faculty practice at Stanford, which is really an ECOG-centric organization, I was not able to get involved for the first few years. However, I continued to be involved in translational research with RTOG through my lab and my work on biomarkers, especially EBV DNA and hypoxia markers, and attending the meetings. After a few years, I was able to negotiate for clinical research support with my chair at the time, who was Dr. Hoppy, to open some RTOG head and neck cancer trial at Stanford. I guess my work got attention with the RTOG NRG Oncology leadership, so that in 2011, I was selected to succeed Dr. Quynh when he decided to step down from the head and neck committee chair position. 10 years later, in 2021, when Dr. Kern stepped down from his group chair position, representing the R part of NRG, I applied for the position, interviewed, and was selected by the search committee to replace him. So that was my story of involvement in NRG.
And I know that you're in the midst of preparing for the National Cancer Institute grant submission for NRG Oncology. I was wondering if you could tell us a little bit about how NRG fits into the bigger picture for the National Cancer Institute, or the NCI, and what are going to be our biggest aims and priorities for NRG in this submission.
Yeah, so as I mentioned previously, we're part of the NCTN, and we're likely, probably by membership standpoint and enrollment standpoint, the largest of the adult groups in the group. The other ones, including the Southwest Oncology Group, the Lions, ECOG Akron, and the Canadian Network. Each funding cycle is about 6 years, so we will be resubmitting our competitive grant renewal this year. To leverage on our current and past strengths, we will continue to maintain the two themes that I mentioned about previously. One of them is on gender-associated malignancies, and the other one is on locally advanced malignancies originating from the sites that I mentioned previously. Our aim has been and will continue to focus on more biomarker-driven trials to really enhance precision medicine. We want to test and integrate novel technologies, such as that of radiation, surgery, AI, into the clinical trial. And we want to evaluate novel therapeutics, including diagnostic, either by themselves or together with existing treatment in early and late phase trials. So those are really, we're still working on the grant, as you know, but those are brief summary of our themes.
That sounds fantastic. Apart from those larger long-term goals and grant-focused goals, are there particular short-term goals and initiatives that we as NRG need to work on this year?
Yeah, so as you know, the length of the trial span years. So we have a lot of trials that we proposed and recently approved, so we need to activate them. We need to accrue very well, or either on time or ahead of time, to our currently open trials. And we need to analyze, publish, and disseminate the results of our recently completed trials once all the data is in. We also want to perform translational and secondary analyses of our completed trials to generate data and hypotheses for our new trials. At the same time, we also want to engage more new and early career investigators in the organization. We want to diversify our organization, and we want to continue to grow our organization. So these are just some of the short-term goals that we are doing this year, but it's spanning through the life cycle of the grants as well as the growth of the organization.
And everything we do at NRG really depends on patients being willing to participate in clinical trials. So you've got your patient out there. For the patient who might be contemplating participating in a clinical trial for cancer, might you briefly describe what is often a huge amount of work that goes into ensuring that a concept is sound and that we're doing right by our patients?
I'm going to try to be brief, but it won't be as brief as you hope for, because developing trials take about 2 to 3 years. I'm going to try to summarize it in the next couple minutes. But the way the NCI and its grant structure is created, we actually have 2 types of study based on the primary endpoint. If the primary endpoint is on survival, such as overall progression-free or disease-free survival, then it will be managed by the CTEP side of NCI and the disease site committee within NRG. If the primary endpoint is on patient-reported outcome, quality of life, cancer prevention, detection, or cost effectiveness, etc., those that are really not focusing on survival, then it is managed by the DCP side of NCI and the NCORP side of NRG Oncology. Because of time constraint, I would pretty much focus my comments on the CTEP side, because that's where the majority of the concept and trial are, because they focus on survival endpoint. But also the process on proposal to protocol development between the CTEP side and the DCP side is different. So I want you to take a look at attention very much on the website. On the NCORP side, it's very well articulated on the website. So I'll ask you to look into that. CTEP's trial usually start with a hypothesis that an investigator or group of investigators have. It's then vetted across the disease site committee, start with the core, a group of the disease site, and then the general group of the disease site. Along the way, if the concept rises to the top, then it gets statistical supports for sample size estimation, etc. After that, it will go through NRG research strategy, where it's reviewed by leadership across the group and across the different disease sites. All NRG Oncology research strategy members are asked to vote on each concept for both scientific values as well as feasibility. Then after that, the research strategy executive committee will review the votes and identify the approved concept to move forward. The NRG approved concept will then be prioritized by the disease site to submit to the NCI for the NCI disease-specific task force and steering committee for review. Sometimes some disease site will have task force and some don't, and the task force review is often meant to be advisory. The approval is needed from the NCI steering committee for the concept approval to develop into the protocol. This is one of the most crucial steps, as each concept can receive a decision of approved, disapproved, or pending on the first round, just like a manuscript. However, you can only come back once if you get a pending decision. If the improvement is adequate, then it will be approved. And if it's not, then it will be disapproved. Depending on the strength of the concept and the steering committee, the overall chance of approval can range anywhere between 30 to 60%. If the concept is approved by the NCI disease-specific steering committee, a full protocol will then be developed, and it takes another year because prior to releasing the protocol to sites, it needs to be reviewed multiple times by the NCI, the central IRB, and if needed, the company that provides the experimental drug. So as I mentioned, on the average, it'll take about 2 years or longer from a concept inception to protocol approval. In addition to disease sites experts, we are fortunate to have a very engaged committee of patient advocates with expertise covering all different disease sites. The patient advocates provide inputs along the way at many steps that I have outlined to ensure that the trial is relevant and feasible to patient. We also have a very active health disparity committee that works with individual disease site to ensure that the developed protocol is feasible for patients across all walks of life. So I hope, it's a long-winded answer, but I hope that summarized some of, I would say, mystery of how protocols develop behind the scene within NRG. And I think a very similar structure is seen for most of the NCTN.
I think you're doing a tremendous job of helping us pull back the veil on some of these aspects. Clearly, there are a lot of elements, steps, and also safeguards that go into ensuring patient safety as part of these trials too. And it's interesting that numerous studies suggest that patients enrolled on clinical trials across the cancer population might indeed have better survival or outcomes than non-enrolled counterparts. Can you speak a little bit about this observation and shed some light on some of the factors that might help to explain observations like this?
I think that's a very important aspect of participating in clinical trial. And I often emphasize to patients when I discuss clinical trial with them. I'm not sure if I can shed a lot of light on that. A lot of these are guessing. But I think in addition to the safeguards that you mentioned, we have local research coordinators who keep a very close eye on patient. And they do alert physicians of issues sooner than those likely treated off protocol. Likely there may be some biases in patient selection, as we do tend to enroll the most fit patient with less social economic barriers and strong family support, etc. And so that does make our result potentially less generalizable to non-trial patients. Therefore, we acknowledge this and we have worked very hard to make our eligibility criteria much broader, such as including less rigorous patient with ECOG performance status 2 and less stringent lab requirements. We also try to minimize the number of tests required, as well as allow patients to receive a lot of cares, labs, and imaging studies near home. We hope that it can enhance clinical trial access to more patients, especially rural patients or those with minimal transportation to mean. Again, I'm guessing a lot of these, but I think it's a very important aspect to emphasize again and again for the patient is that trial participation, for some reason, improve overall survival across the different disease sites, across different trials.
Well, Dr. Lay, I want to thank you again for joining our inaugural NRG podcast and for your leadership of NRG Oncology. In closing, we want to disclose that the NRG Oncology Group is supported by grant funding from the National Cancer Institute of the National Institutes of Health, and content in this podcast is not necessarily representative of the official views of the NIH. Thanks again, everyone, for tuning in, and happy trials.